Good evening, everybody. Welcome to our Fireside Chat. My name is Dr. Mazhar Amiradi. I'm a physician and a nephrologist working with Africa Health Network in the capacity of Deputy Chief Medical Officer and Country Medical Director. We would like to welcome you all for this evening's Fireside Chat, which is going to be conducted by Dr. Hormaz Dastoor, who currently serves as a nephrology consultant at Seha Kidney Care in Sheikh Shakhbout Medical City. He finished his training in nephrology at Columbia Presbyterian and Cornell Hospital in New York City. He's actually not the first time that he's been here. He's been here with us before, giving us a talk on hypernatremia, which was very engaging. His main interests include general nephrology, glomerulonephritis, electrolyte disorders, and sodium kinetics. And this evening, he's going to take us through new treatment opportunities in the management of chronic kidney disease in type 2 diabetes, exploring the role of finerenone from the trials to real-world practice. Dr. Dastoor, thank you very much, and please, the floor is yours. Thank you.
Thank you. Good evening, and thanks for inviting me again to your lecture series. Today, I just want to talk to you about CKD management in type 2 diabetes. For the last 1.5 years, we have been using a new drug called finerenone, which belongs to the group of mineralocorticoid receptor antagonists. It's a little different from spironolactone. I just want to show you briefly the trials that are available for this study, why we started using the drug based on certain trials, and what has been our experience, and where I think the drug will be used in the future. So as you are aware, CKD in type 2 diabetes has a high global disease burden. You can say approximately 500 million people worldwide have diabetes, and the majority of them, about 90%, are type 2 diabetes. And as we all know, about 2 in 5, or around 40%, of these patients end up with some form of chronic kidney disease. So why is chronic kidney disease important in type 2 diabetes? Because it's not only important because CKD will lead to renal failure. We can treat that by transplantation. However, CKD and type 2 diabetes is associated with cardiovascular mortality. And as a nephrologist, I think we should be concerned more about cardiovascular mortality, or I would say at least as we are concerned about progression to hemodialysis. So here you can see that the 10-year cumulative cardiovascular mortality for somebody who doesn't have diabetes or CKD is around 3.4%, whereas somebody who has CKD and type 2 diabetes, their 10-year cardiovascular mortality is around 20%. That means 1 out of 5 in 10 years of these patients will be dead. And we all know that cardiovascular mortality in diabetes increases with albuminuria and also as EGFR declines. So we know that urine albumin creatinine ratio more than 30 is associated with increased cardiovascular mortality. But sometimes we're not aware. If you look at this curve over here, the rise in mortality actually increases even when your urine albumin creatinine ratio is less than 13 milligrams per gram. And between 10 and 30 is where there is a significant increase in your cardiovascular mortality, right? This is where the delta goes up. And I think that's where we should be focusing. But perhaps, even though the guidelines tell us to try and bring down the urine albumin creatinine ratio to around 30, perhaps in the future, looking at the cardiovascular mortality, maybe these guidelines will go even further to around 10 milligrams per gram. And also at the same time, on this curve on the right, you can see that as our GFR declines, your cardiovascular mortality increases. Now we know that the diagnosis of CKD is basically made from two tests. The number one test is the eGFR, and number two test is the urinary albumin creatinine ratio. And I always tell my residents and trainees that the definition of CKD, as highlighted, is basically a eGFR more than less than 60 ml per minute, or a urine albumin creatinine ratio, which is more than 30 milligrams per gram, which is persistent for more than 3 months. Yeah, so if you have a single test result, you cannot theoretically classify these patients. And most of our KDIGO guidelines and even the American Diabetic Association, they recommend that all patients who are diabetic should have an eGFR and urine albumin creatinine ratio measured at least once a year. And if your eGFR is less than 60 or albumin creatinine ratio is more than 30, then you should be doing these tests at least twice a year. Now, this is the first time we have done any population evaluation of chronic kidney disease prevalence in the UAE. So nothing has been published in the literature. So I just wanted to highlight what we have seen in our patient population. In the UAE, there are approximately 10 million people, out of which 9 million are expat population. If you look at the population pyramid, there is kind of a disproportionate increase in the number of men relative to women. So there are about 3 times as many men as compared to women. And another difference in the population curves, if you see this is a bell-shaped curve, so the mean and median are the same. But if you compare it to Western countries, the mean and median population in the UAE is quite young. And I think that may be true also for African countries, that our populations are much younger as compared to the Western countries. So theoretically, we would expect that because of this younger population, the CKD prevalence would be much lower. However, when we looked at CKD prevalence in the UAE, especially in Abu Dhabi, when you look at CKD2 to CKD5, we found that about 23% of the population was found to have around some stage of CKD. And this compares to the US RDS data, where they looked at CKD1 to CKD4, where approximately 15% of the US population. So in Abu Dhabi, we figured that if we included CKD1 to CKD5, approximately 30% of the population would have CKD. So the prevalence of CKD 1 to 5 is, I would say, about twice the rates as in the US population. However, having said that, there are few differences. In the UAE, the majority of the cases were around CKD2, and then the minority was CKD3, 4, and 5. So why is that important? Because when we project the dialysis needs for the future, we know that going from CKD2 to CKD3 may actually take anywhere between 11 to 15 years. CKD3 to 4 may take around 5 to 7 years, and CKD4 to 5 may take around 2 to 3 years. So even though our CKD rates are much higher than other populations, there is some solace in the fact that our CKD population, the majority of it is CKD2, so the progression rate will be to ESRD will be much slower than in other populations. Now, what do we do about CKD progression in type 2 diabetes? So if you look at the drivers for CKD progression in type 2 diabetes, there are 3 main drivers. Number 1 is hemodynamic, number 2 is metabolic, and number 3 is inflammation and fibrosis. So these 3 factors basically lead to glomerular hypertrophy, mesangial expansion, glomerular sclerosis, and tubulointerstitial damage. And how do we prevent CKD progression? We know the causes. So if we are looking at reducing blood pressure and intraglomerular pressure, I'm from the old school, so I still remember the time where we used thiazide diuretics when ACE inhibitors were not prevalent. And I also remember the time when we used dihydropyridine calcium channel blockers. So for the young physicians, you should be aware that these drugs will also reduce proteinuria. But obviously, from the early, I would say late 80s and early 90s, they were replaced by ACE inhibitors and ARBs. And subsequently, in the last 4-5 years, we have added SGLT2 inhibitors based upon, the DAPA CKD and the EMPA kidney trials. In terms of metabolic control, obviously we have SGLT2, GLP-1, metformin, and other anti-hyperglycemics, but the only two groups of anti-hyperglycemics that are found to have renoprotective effect are the SGLT2 inhibitors and the GLP-1 receptor antagonists. And I'm sure everybody knows about GLP-1 because seems like there is a pandemic and people are going crazy with these drugs. But however, we haven't focused on the third driver, which is inflammation and fibrosis, right? So we tended to neglect that. And currently there are no treatments for treating inflammation and fibrosis. So in terms of ARBs, do we have any evidence-based trials which showed their benefit? So quickly, I just want to remind you of the renal trial and the IDNT trial, which was basically comparing losartan and irbesartan versus placebo and amlodipine. And this was in high-risk groups of patients with CKD. Typically, they had moderate to severe albuminuria around 1.2 milligrams per gram or nearly 2 milligrams per gram. And if you look at these two curves, there was a significant improvement in the primary composite outcomes, around 16% and around 20%. So these trials definitely showed that ACE and ARBs were effective in preventing progression of CKD. In terms of SGLT2 inhibitors, we have 3 trials. I just want to show canagliflozin and the DAPA CKD. The CANA study was purely in diabetic patients. There was a 30% reduction in the incidence of primary composite outcome, but here it included kidney outcomes and cardiovascular outcomes. And as well as in DAPA CKD, there was around, I would say, was it 30, around 43% overall reduction in the composite outcomes. And these were also in quite high risk group patients. They had significant proteinuria, close to 1 gram. So there was a risk reduction in events, but still there is a significant residual risk to which our CKD patients are exposed. So can we reduce that risk even further, right? So one theory that goes out is that patients who have CKD or who have heart disease have excessive mineralocorticoid receptor activation. And whenever there is excessive mineralocorticoid receptor activation, there is an increased expression of inflammatory and pro-fibrotic factors. This causes inflammation and fibrosis both in the kidney and in the heart, which will result in end organ damage. And if we can maybe reduce this mineralocorticoid receptor activation, perhaps the theory goes that we can reduce inflammation and fibrosis in the kidney and the heart. So this is once again highlighted here. You can see patients with heart and kidney disease, whenever the mineralocorticoid receptor gets overactivated, and I'll show you overactivation of the corticoid receptor is not only by aldosterone. So we as nephrologists have a misconception that the mineralocorticoid receptor is stimulated by aldosterone, but that's not the case, as I will show you. But regardless, whenever you stimulate the mineralocorticoid receptor, there is an increased gene expression of pro-inflammatory and pro-fibrotic mediators, which causes inflammation and fibrosis in the kidney, in the vasculature and the heart, basically giving rise to kidney damage and heart damage, mostly through inflammation, fibrosis, remodeling, LVH, ischemia, etc. Okay. Now here you can see that this is the mineralocorticoid receptor. Typically, it can be stimulated by aldosterone, but it can also be stimulated by cortisol. There are certain inflammatory cytokines known as RAC1. Hyperglycemia can also directly stimulate your mineralocorticoid receptor, high salt load, or oxidative stress. This results in release of inflammatory and fibrotic cytokines. If you can block this mineralocorticoid receptor, the theory is that you can block this inflammation and fibrosis. The most common and the most aware mineralocorticoid receptor that we are all aware of is spironolactone. However, we have the so-called new kid on the block, which we have available now, at least in Abu Dhabi for the last 2 years. And this one is finerenone. And the question you may ask is, okay, what is finerenone? How does it differentiate? How is it different from spironolactone? Why should I use finerenone? Do you have any clinical studies to show benefits of finerenone in chronic kidney disease? Because we don't have any of those studies, at least for spironolactone. So finerenone, as compared to spironolactone, is a non-steroidal MRA. So that's important. Spironolactone is a steroid MRA. Finerenone is a non-steroidal MRA. The structure of finerenone is such that it fits exactly into the mineralocorticoid receptor. And because of this strong binding, it has stronger selectivity for the mineralocorticoid receptor, giving it a better half-life and less side effects. So basically, it is known to reduce inflammation and fibrosis based upon preclinical studies, which I will not show you today. I'll just show you the clinical studies. It has a less incidence of electrolyte disorders like hyperkalemia, which is the major problem with spironolactone. It has less sexual side effects like gynecomastia or erectile dysfunction or dysmenorrhea. So maybe women may not like finerenone, maybe women may prefer spironolactone, but overall it has less side effects. So for men, obviously the absence of gynecomastia is a plus for use of finerenone. And as I told you, the risk of hyperkalemia is less. And unlike spironolactone, which may have an effect on blood pressure, I'm not sure if it is good or bad, because sometimes we do use it for resistant hypertension. Finerenone in clinical trials does not have significant effect on blood pressure, but in real world trials, I will show you there is an effect on blood pressure. So I will also show you cases where I have used finerenone for resistant hypertension, even though the clinical studies show that they have no effect on blood pressure. So what is the clinical evidence we have for renal and cardiovascular benefits? Well, we have major trials which were published in a major New England Journal of Medicine, and these are the 3 trials. That is the Fidelio, Figaro, and Fidelity studies. So these studies were carried out in different countries around the world, and they recruited around 13,000 patients. So this is one of the largest studies of chronic kidney disease in diabetic patients. I think no other study has recruited so many patients. The Fidelio study was basically looking at finerenone in kidney failure as primary outcomes. whereas Figaro study was mainly looking at cardiovascular and mortality and morbidity in patients with chronic kidney disease and type 2 diabetes. Okay, so there are some subtle differences in how the trials were designed, because the trial investigators were looking at different outcomes. Okay, so I just want to explain it to you briefly in detail. So Fidelio was basically a renal outcomes study. So if you want to show benefits of this drug, you need to use patients who are in a high risk group, patients who are in CKD4 or CKD3, or patients who have significant proteinuria. Because when you compare it to the standard of care, you need to have a certain number of events, and you need to show that the drug that you are investigating is able to reduce those number of events. If the event rate is low in both the standard of care and in your investigative drug, then basically that trial will be fruitless, right? As an example, let me take the rituximab studies in lupus. In both the rituximab group and the standard of care group, the event rates were very low. So you could not show a difference in outcomes between rituximab and the standard of care. So having learned those lessons, the primary investigators in the Fidelio, where they wanted to show renal outcomes, basically looked at renal outcomes in patients who had a higher degree of, higher risk of progression of CKD, and they wanted to use Fidelio and show that there was a positive outcomes. So if you look at the Fidelio trial, you can see over here in the Fidelio trial, the majority of the patients had significant proteinuria as compared to Figaro trial, which was a cardiovascular outcomes. In the Figaro trial, you want to look at cardiovascular outcomes in patients who have stable chronic kidney disease. Because you know that if you take patients who have high risk of progression, the fact that they will migrate from CKD3 to CKD4 automatically increases the risk of cardiovascular risk. So you may not be able to show that the drug has any benefit. So in the Fidelio studies, you took patients who had high risk of CKD progression. In the Figaro study, where you're looking at cardiovascular outcomes, you took patients who had lower risk of CKD progression. So the majority of the patients over here had relatively less degrees of proteinuria. If you look at the eGFR categories, you can see that in the Fidelio study, they took patients who had much more severe chronic kidney disease. That means the majority had CKD4 and CKD3. So they had a higher risk of progression, and you wanted to show that the drug finerenone was able to reduce the risk of CKD progression. And in the Figaro, you had patients who were primarily CKD1 and CKD2. They had stable chronic kidney disease, and you wanted to show positive cardiovascular outcomes. So that's how the trial was designed. So after a screening period, where majority of the patients were treated with an ACE or an ARB, finerenone was added in the investigative group, whereas in the placebo group, it was compared to the placebo group. As I told you, in the Fidelio study, the primary outcome was kidney outcomes, looking at the risk of kidney failure or decrease in GFR. And the secondary outcome was the primary outcome of the Figaro study. So the secondary outcomes were looking at cardiovascular outcomes. In Figaro study, it was the reverse. The primary was the cardiovascular outcomes, and the secondary outcomes was the renal outcomes, which was the primary outcomes in the Fidelio study. So it was just an interchange in the outcomes. And besides this, they also looked at other parameters such as all-cause mortality, hospitalization, change in urinary albumin creatinine ratio, and the eGFR decrease in 57%, which is basically the doubling of serum creatinine. So going straight to the results, you can see that in the Fidelio study, if you're looking at the kidney outcomes, you can see that after 12 months, there was a divergence in the outcomes between the placebo group and the finerenone group, with a favorable outcome around 18% relative risk reduction in the finerenone group compared to the placebo group. So the absolute risk reduction was around 3.4%. And the inverse of the absolute risk reduction, which is the numbers to treat, was around 29. So that kind of highlights, that you don't see an immediate benefit by adding this drug because you are trying to reduce or reverse inflammation and fibrosis in the kidney. So that takes time. So that's why there was approximately 12-month period after which only you started to see benefit of this drug, and you can see the benefit persisted for beyond the 36 months of the trial. In terms of the secondary outcomes, which was the cardiovascular outcomes, again, over here, it favored finerenone. There was 14% reduction in cardiovascular outcomes. The absolute risk reduction was 2.4, and numbers to treat was 42. But here you can see the difference, right? Here, immediately, there's a divergence in the two groups. So what does that mean? I mean, you can say, well, why does it take shorter time for finerenone to reduce cardiovascular cardiac fibrosis or arterial fibrosis? I don't think this is related to fibrosis. I think finerenone may just have a slight diuretic-like effect, and that diuretic effect maybe reduced your intravascular volume, and maybe that was a benefit in patients who were at high risk of heart failure, especially in this group, in the Fidelio study, where we had patients with CKD4 and CKD3, patients whom we know are slightly volume overloaded, and perhaps use of this diuretic effect in finerenone had a benefit in these patients, and perhaps that's why you saw an immediate improvement in the cardiovascular outcomes as compared to renal outcomes. If you look at the reduction of the urine albumin creatinine ratio, overall, the urine albumin creatinine ratio reduced by 31%. So that's a significant decrease, yeah? Comparable even with SGLT2 inhibitors and ARBs, because those drugs, they kind of produce a similar reduction in urinary albumin creatinine ratios. So now we have at least three drugs which are proven to reduce urine albumin creatinine. One of them is ARBs. The second one, as we know, is SGLT2s. And the third pillar, as we like to say now, is probably finerenone. Does finerenone reduce the GFR? Yes, but not like ARBs or like SGLT2s. There is no significant effect on renal hemodynamics. There is a slight decrease initially in GFR, probably related to this diuretic-like effect. But then you can see that the rate of decline in finerenone compared to placebo in these high-risk groups, where on average, if your GFR is declining by 4 mLs per minute, finerenone reduced that to around 2.6 ml per minute. So around 1.5 ml per minute per year, less reduction. So if you time that out over 10 years, that's around 15 ml per minute per year. And that may be the difference between your patient ending up on dialysis or not going on dialysis. Yeah, so that is a significant difference. If you look at the Figaro study, which was looking at primary cardiovascular outcomes, you can see that there was a benefit in cardiovascular outcomes, 13%. In the Figaro study, there was no benefit in the renal outcomes, right? So you may ask me, oh, so you mean to say this drug is not effective? You just told us that in the Fidelio study, in renal outcomes, it was effective, right? But you need to understand why there was no significant benefit. It was simply because as I told you, the study trial was designed that the patients in the Figaro study, they were in CKD2, CKD1, or maybe CKD3, but the majority were in CKD1 or CKD2. So you know that CKD1 and CKD2, they progress very quickly. To show a benefit of these drugs in patients who don't have any events in what I mean by events is progression from CKD2 to CKD3 or CKD4 to CKD5, because these are very low risk patients. So obviously you do not see a difference between the placebo group and the study group, that is the finerenone. So that was the only reason why you did not see a benefit of finerenone when you're looking at secondary outcomes. But if you look at long-term outcomes, that is sustained 57% decrease in GFR, which is doubling of serum creatinine, over there, obviously there was a benefit, yeah? So just to summarize, between the Fidelio and the Figaro, the Fidelio was primarily a renal study looking at renal outcomes. It looked at renal outcomes in high-risk groups such as CKD3 and 4. Figaro was looking at cardiovascular outcomes in low-risk patients at low risk of CKD progression. And Fidelio study was positive in terms that it did show a decrease in CKD progression and cardiovascular mortality. And the Figaro study did show reduction in cardiovascular mortality and a non-statistically significant reduction in CKD progression. Yeah, so if we look at this hot chart, you can clearly see that Fidelio was basically patients with CKD3 and CKD4, and they had higher proteinuria, whereas the Figaro study was basically CKD1, CKD2, CKD3, and with lower degrees of proteinuria, right? And the Fidelity study was basically a kind of an analysis of both, combining patients in the Fidelio and Figaro study, and it kind of showed the same results. Yeah, there was an overall 14% risk in reduction in risk of cardiovascular outcomes, and about 23% reduction in renal outcomes. Did finerenone in the study change blood pressure over time? So if you look at the composite mean of all the blood pressure changes, it was not significant, thought to be around 2 millimeters mercury or 2.5, not enough to affect the positive outcomes that we saw in terms of cardiac and renal outcomes. It did not change hemoglobin A1C, so we can conclusively say that the benefits were not attributed to better control of sugars. Did finerenone, like spironolactone, affect serum potassium? At least in the controlled settings of a study, there was only a slight increase as compared to the placebo group, and that difference was around 0.2 millimoles of potassium, not significant, yeah? 0.24 millimole per liter of potassium. So unlike spironolactone, in which hyperkalemia can be a limiting factor, in finerenone, at least in the clinical trials, there was no significant increase. Here you can see that compared to placebo, there was no cause of death. There was an increase in hospitalization rates related to hyperkalemia and leading to an increase in permanent discontinuation, but not that high compared to spironolactone, where trials of spironolactone have shown between 11 and 23% rates of discontinuation. Yeah. This slide I got from the drug company, which basically shows an idea of how we use the drug. So if your GFR is less than 60 ml per minute, the recommended dose is to start 10 milligrams. If your GFR is more than 60 ml per minute, you can start at 20 milligrams. The company doesn't recommend to use it when your potassium is 5. Do we follow this recommendation? Yes. we try and bring it down, and then we use finerenone. I also want to highlight, if a patient has had hyperkalemia in the past 1 year, but currently doesn't have hyperkalemia, and if you are planning to start finerenone, then we recommend putting them on an anti-hyperkalemic agent at the same time. So what I mean is, if my patient's potassium is 4.8, I can start him on finerenone. But if I go back to his file, and if I see that in the last 12 months, even if he was not on finerenone, he had a hyperkalemic event, then I would start him on finerenone with an anti-hyperkalemic agent. Okay, so based upon this New England Journal trial, the Fidelio and Figaro study, the KDIGO guidelines recommended to have a non-steroidal MRA with proven kidney and cardiovascular benefits, which is basically finerenone in patients with type 2 diabetes and eGFR greater than 25 ml per minute, especially in patients with normal potassium and an albuminuria, which is greater than 30 milligrams per gram. Okay, and the same is with the American Diabetic Association. They do recommend the use of finerenone or non-steroidal MRA in patients with type 2 diabetes and CKD, a drug which is known to have proven cardiovascular benefits and which is known to reduce the risk of CKD progression. So this was a summary of the trials. And now I just want to go a bit clinical from what experience we have gained. So during our use of this drug, a lot of my residents and fellows will ask me, finerenone, we looked at the trials, it only produces a 13% reduction in proteinuria, whereas look at SGLT2 inhibitors. They reduced kidney outcomes by 30%, and they reduced cardiovascular outcomes by 30%. So why should I use finerenone? Why don't I just stick with ARBs and EMPA or DAPA or canagliflozin? So I want to highlight how we interpret studies, right? You cannot compare apples with oranges, right? You need to compare apples with apples. So what do I mean by that? So if you look at the Fidelio study and the Figaro study and look at the cohort of patients, right? So the only trial which compares with Fidelio and Figaro is the Credence trial, which is canagliflozin. And how does it compare? It compares in the sense that the groups of patients were similar. So this was a trial of 100% diabetic patients, which is same as in Fidelio and Figaro. You cannot compare dapagliflozin or empagliflozin with finerenone because the cohort of patients are completely different. In the DAPA, only 50% were CKD. The rest were like diabetic CKD. The rest were probably IgA nephropathy or other causes. In EMPA, only 30%, so you cannot compare these two trials with Fidelio and Figaro. The closest trial of SGLT2, which you can compare, is probably the Credence trial. And look at the population of the participants. Yeah, if you compare it to the Figaro trial, these are completely different groups of patients. Compared to Figaro, at least you have more patients here in CKD3 and CKD4, and they have more proteinuria. So these are unequal groups of patients. You cannot really compare outcomes in the SGLT2 studies with the finerenone trials. Yeah. So this is a study which tried to create an equivalence between an MRA and an SGLT2 inhibitor. So they took the patient population in the Fidelio trial, which was basically 100% diabetic kidney disease, and they tried to take equivalent groups of patients from the Credence trial, which was also patients who had diabetic kidney disease. So if you look at the Fidelio trial itself, as I showed you, the hazard ratio was 0.82. So the benefit was only about 18%, the overall cardiovascular benefits, right? But now, if you look at similar outcomes to the Credence trial, because in the Fidelio, you were only looking at around 40% decline in GFR, whereas in the Credence, they were looking at 57%. So in this study, they looked at what would happen if the finerenone patients had a 57% decline in the eGFR. So they had equivalent endpoints. So if you use an equivalent endpoints, you can see that the equal improvement in the hazard ratio was around 0.78, so around 22%. Now, if you took patients with the same degree of eGFR and the same level of proteinuria, you can see that there was a significant improvement in outcomes favoring Fidelio. So you went from an 18% improvement to a 26% improvement. And then if you took the Credence-like group with the same incidence of heart failure, then you can see the overall benefit or relative risk reduction was around 28%, which is similar to the SGLT2 inhibitors. So what I wanted to show that when you compare, when drug companies come and they tell you, well, our drug is more beneficial because we have a 30%, reduction in cardiovascular and renal outcomes, whereas finerenone only has 18%, that is not true. So we as physicians, we need to understand the differences in how these trials are designed. We need to look at the equivalence of these trials and then see how they compare, yeah? So this is a clear example of how you cannot compare an MRA versus an SGLT2 unless you provide some kind of equivalence in the study population. And this trial is basically showing the same thing. If you look at the Fidelio-like Credence-like subgroup, Fidelio was slightly better or equal to canagliflozin. Okay, now the second question you may ask me is, okay, now we have these three group of drugs. How should I change my practice, right? I have an ARBs. What do I do? Do I start an SGLT2, wait for some time and then start an MRA? Or should I start an MRA first and then should I start an SGLT2? Or should I start all three at the same time? I can tell you that in the majority of my patients who have an eGFR more than 60, I start them on all three medications at the same time. I don't worry about hyperkalemia because SGLT2s are known to reduce potassium because they are caluritic to a certain extent, whereas finerenone potentially could be hyperkalemic, but the two balance out each other. So this was a study I want to show that which used genetically modified rats. They are known as L-name rats. So these rats are modified to mimic the extensive hypertensive proteinuric and inflammatory environment that we see in CKD patients. These rats typically have a lifespan of only 2 weeks because they're extremely proteinuric, high blood pressure, extensive renal and cardiac inflammation and fibrosis. So if you look at L-name rats in general, at the end of 2 weeks, only 53% of them are surviving. 100% of them have proteinuria. Their mean blood pressure is around 200 millimeters of mercury, and they have extensive cardiac and renal histology. When you give them finerenone, either dose, either 1 or 3 milligrams, you will see that their survival goes up to 86%. The proteinuria has decreased by 87%, and the blood pressure has declined. And there was a significant improvement in the reduction of inflammation and fibrosis, suggesting that at least in animal models, there is evidence that finerenone has benefits on blood pressure, proteinuria, inflammation, and fibrosis. This, as compared to empagliflozin, has improved survival, but comparatively less than finerenone. Yeah, you can see the outcomes over here. So this trial may again suggest that perhaps MRAs could be better than finerenone, but until we have really one-on-one comparison in a randomized trial, you cannot really say which one is better. Okay, and then obviously the best benefits were seen when you combine finerenone 1 milligram with EMPA, where at the end of 2 weeks, 93% were surviving, significant decrease in blood pressure and proteinuria. And this is in human studies. I think there is a study coming out, I forgot the name. It's either confidence trial where they're comparing finerenone with an SGLT2 empagliflozin and looking at the same outcomes, cardiac, renal, and proteinuric outcomes. And I think we should have the study results very soon. Okay. Now I want to show you our clinical cases when we started using finerenone for the last, I would say, 1.5 years. So this is case one. I had a 43-year-old male patient, diabetic for 14 years, severely obese, high body mass index. His EGFR was declining. The rate of decline in his EGFR was quite heavy, more than 2 to 3 ml per minute per year. He had significant proteinuria of around between 2.6 and 3 grams while he was on ARBs and SGLT2. We were kind of stuck. He was planning to undergo bypass surgery. He had failed the use of GLP-1s, that was Ozempic. At that time, we didn't have Mounjaro. So anyway, so the drug came on board and we decided to use the drug. And truly, I was really surprised. I didn't expect this degree of reduction in his proteinuria. Now, I'm not sure if this is all the effect of an MRA or whether this was some tail effect of the SGLT2 or the combination of SGLT2 and finerenone having synergistic effect. But regardless, he did have a significant decline of his EGFR, and I'm hoping that over the course of the next few years, I can show that his rate of decline in his EGFR, which was more than 5 ml per minute per year, will be at least 2 or less ml per minute as a result of decreasing his GFR. Yeah. And the second case, I just picked it up 2 days ago. I thought I may just present it to you. I have a 68-year-old lady, CKD4. Baseline EGFR was around 27 ml per minute. I saw her a couple of months ago. The daughter called me. She had a urine protein creatinine ratio of 6 grams per gram. Albumin creatinine ratio. Her serum creatinine was 180. Her EGFR. She was on valsartan. I think the physicians, they were scared to use EMPA and finerenone. So I had a talk with the daughter. I said, most of the studies now have shown, at least for the finerenone, we have data up to 25 ml per minute. For EMPA, we have 20 or even less, going down to 10 ml per minute for EMPA. I said, let's give her a trial of these drugs because, when you have 6 grams of proteinuria, the rate of decline in your GFR is anywhere between 5 and 10 ml per minute per year. So you can see that when I started her on the drug, her GFR declined, right? I started her on both, the combination therapy. And as expected, and as I had told the family, you will expect a decline in her GFR. And yes, her GFR declined to 22, 21 ml per minute. And it's kind of stuck now around 21, 22. I don't expect it to improve, but I'm hoping it will not decrease. But look at her proteinuria. These are not made up numbers. Yeah, I didn't make up these numbers. She went from 6 grams of proteinuria, she went to 2 grams, and now progressively, I think this is the effect of SGLT2 and the MRA, and she is down now close to around 1.5 grams of proteinuria. Her edema, her daughter has, this is a funny case. I have actually never seen this patient. That's a true story. This patient has been treated by telemedicine because the patient is very religious. She doesn't want to see any physicians. Her daughter, who's a physician, is treating her through me. And though she tells me her edema has declined significantly, the amount of bubbles that she sees in her urine signifying proteinuria has gone down, so this is a good case of a combination therapy having benefit in these groups of patients. Yeah. Now I want to talk slightly about the role of finerenone and hypertension. When you looked at the combined Fidelio-Figaro study and 13,000 patients, the mean decline in blood pressure was not significant. It was only around 1.3 millimeters of mercury. And that compares to spironolactone, where you see studies of spironolactone in the AMBER trial, around 11 millimeters of mercury, right? So obviously spironolactone is a good antihypertensive. And you may tell me, well, finerenone is a good MRA, but I don't think it's a good antihypertensive. And if you look at evidence-based, yes, a drug that reduces your blood pressure by average 1 millimeter mercury is not an antihypertensive drug. But a sub-hoc analysis where they looked at patients in the Fidelio and Figaro studies who had resistant hypertension. So there was a subgroup of patients who had very high blood pressure. And in those group of patients who had high blood pressure, you can see that there was a significant decrease in their blood pressure. So finerenone is like spironolactone and ARBs in the sense that when you give them to normotensive patients, there is no decrease in blood pressure. And we know that spironolactone, when you give it to patients with heart failure, whose blood pressures are systolic is 80 or 90, they can tolerate it because in these patients, spironolactone or ARBs, they don't reduce their blood pressures, right? But when you give spironolactone or ARBs to hypertensive patients, they produce a pronounced decline in the blood pressure. And finerenone has the same qualities. When you give it to normotensive patients, there is no decline in the blood pressure. But when you give it to hypertensive patients, there is a decline in their blood pressure. Yeah, so keep that in mind. And the benefit of decline in blood pressure comes without hyperkalemia. So in the Fidelity trial, the risk of hyperkalemia was not very high. When you look at spironolactone, the risks are close to around 64% to 34% risk of hyperkalemia in spironolactone. Yeah, and this is a clinical case, another case. So I had a young girl who was newly started on hemodialysis. She had severe intra and interdialytic hypertension. She was on multiple medications, carvedilol, amlodipine, telmisartan, prazosin. We had also tried clonidine, but she always had resistance. And you can see her systolic blood pressures were always during dialysis, were going from 160 up to 200, 220, multiple admissions to the emergency room. Diastolic blood pressure is between 100 and 120. I was scared that this young girl may end up with an intracerebral hemorrhage. But then I said, let me just try this new drug, finerenone, based upon the previous study that I showed you. Because after reading that study, within 2 days, I started this patient, yeah. And you can see that there is a decline. And the average blood pressure has declined. So here you can see within 1 week, now on dialysis, she's going from pressures of around 200 to around 160, still high, but look where we are compared to before. So this kind of gives you some satisfaction and kind of gives you some, it avoids the stress that, your patient is going to go and have a cardiac event or intracerebral event. The diastolic blood pressure is also decreased. You can see over here that now she went from around 130 diastolic. She was averaging anywhere between 90 and 110 diastolic. Yeah. So I just want to point out that finerenone has not been approved for the treatment of hypertension. Yeah. This is an off-label use. So you cannot quote me that you can use this drug for hypertension, but I'm just trying to show you my experiences with this drug. And this is my last slide, Finerenone is a relatively expensive drug, similar in price to SGLT2 inhibitors. So the question you may ask me is that, is there any benefit of using this drug? So, in major health systems, especially in Europe, they do what is called a cost review analysis, where they see that what is the cost of one QALY, right? One QALY is a quality adjusted life year. And what is the ICR is the incremental effective cost analysis ratio. Yeah. So if you want to give 1 year of extra life to the patient, what is the extra cost of finerenone? So in this trial, what they did was they took the participants of the Fidelio and Figaro study, and they estimated that over the life course of this patients, so let's say if the average age of the participants was 50 years, and you expect them to live 30 years, the cost of the medication, extra costs would be around 3,000 euros, but the cost is mitigated or reduced because when you prevent CKD progression, you prevent dialysis in these patients, you reduce cardiovascular events. So the overall cost is actually going down. Yeah. So for each patient that you use finerenone, based upon the criteria of inclusion into that study, the average cost over the lifespan is negative. So this is an unusual situation because whenever you add a new drug to the standard of care, the cost is always positive, right? But finerenone, the cost is negative. So automatically adding that drug to your patients, you are saving money. So based upon this, immediately the drug was approved for prevention of progression of CKD and cardiovascular risk in diabetic CKD patients. Yeah. And basically, when you have a negative, the cost-effective analysis study stops over there. You don't need to do any further analysis, right? So overall, if you had to summarize finerenone, I can say that it is a new drug. We use it extensively in patients with CKD and type 2 diabetes. Off-label, I am also using it for non-diabetic CKD. I have started using it for IgA nephropathy, etc., so as to reduce the proteinuria further, because we know that in IgA, reduction of proteinuria to less than 0.3 grams is one of the core treatment goals. I have not been using it off-label for hypertension unless we have resistant hypertension in dialysis patients, right? So patients in whom I was planning to use spironolactone in dialysis patients for severe resistant hypertension as a last choice. I am more comfortable using finerenone because of reduced risk of hyperkalemia. And I also showed you the trials, the Fidelio and Figaro. I showed you the case studies where I used finerenone by a subsequent add-on to an SGLT2 or as an initial combination therapy. And I think I showed you the cost-effective analysis where the drug is cost-effective. And if your health system uses this model for approving drugs, so this is a good case index for you to present to your health system to get approval of this drug. Thank you.
Thank you very much, Dr. Dastoor, for this eloquent presentation. I thoroughly enjoyed it, and I can see quite a lot of our participants are also quite commending the presentation and that they enjoyed it. So thank you very much. We'll open the floor for questioning. Maybe if I can just start off, and then we'll let the participants go ahead. Dr. Dastoor, maybe just for interest's sake, in the case that you presented for the young lady with hypertension, newly diagnosed or with CKD on dialysis, she was an incident dialysis patient that was, initiated on hemodialysis. And so, and you initiated the finerenone. My question is that how was her fluid status, given that she was a new dialysis patient?
She was a couple of months. Yes. The fluid status was euvolemic because, at least in our dialysis unit, our assumption is any hypertension is volume related. So we try and squeeze the patients as much as possible. But that about 5% of them, no matter how much you squeeze them, and paradoxically, sometimes when you squeeze them, they become more hypertensive because of that sympathetic disease, right? So that's why we try to use drugs which tend to block the sympathetic system. That's why she's on a alpha beta blocker, carvedilol. She's on telmisartan. She was also on clonidine before, but clonidine had to be stopped because there were some issues with compliance. And, when you stop clonidine, you get rebound hypertension, So that's why for her own safety, we stopped the clonidine, and then we had finerenone just to see if there was any benefit. And saw the benefit of this drug per se, this patient, that's all I can say. Now,
thank you
maybe some of the benefit, I would say, could be the diuretic effect of the drug. I'm not sure, because this lady still had she had good urine output, and I'm not sure if the natriuretic effect of this finerenone played a role or not, but I don't think it caused such a severe drop in her blood pressure, as say. I think it maybe some vasodilatory effects, which may have contributed to her decrease in her blood pressure, or blockage of the sympathetic system. I'm not sure of the mechanism, but blocking her MR receptor seems to have made a difference in her extremely high blood pressures. Yeah.
All right. Thank you very much, Dr. Dastoor, for that. Maybe just another question on the patients that you presented with the proteinuria with addition of the finerenone. I just want to ask, so the duration of the proteinuria drop was significant. It was about 5 months, in this patient. Okay.
My experience, what is happening is that we are seeing both with SGLT2 and with MRAs, seeing an initial drop in proteinuria, and then we are seeing a progressive decline in proteinuria over the next 12 months, So now when I'm following up these patients longer term, let's say they started with 2 grams of proteinuria, 1.5, 1 gram, then slowly they're going down to 0.8 grams, 0.6. So they haven't still reached that plateau, as such. So I have been following them for at least 1 year, 1.5 years, and majority of these patients, even after 1.5 years, are still showing progressive decline until they reach around 300 milligrams or so of proteinuria, and then it's kind of staying stagnant. So that's what I have been seeing with this medication.
Yeah, and obviously the aim is to reduce the proteinuria, perhaps, to prevent, progression of kidney disease. We may not necessarily get them to no proteinuria at all. So I think whatever decline that we have is actually beneficial for them rather than not having the decline at all. So I would still probably take that.
I remember one slide which was published by Professor Remuzzi in 1992 from Diabetic CKD, which always is imprinted in my mind, where he showed that if your proteinuria is less than 1 gram, your rate in decline in GFR is less than 3 ml per minute. If it is between 1 and 3 grams, your GFR decline will be 6 ml per minute per year.
Mm.
And if it is more than 3 grams, it is 9 ml per minute. So that's why my aim is always to try and push them into that less than 1 gram of urea per year. So at least you are reducing the decline in your GFR. Yeah.
All right. Okay, great. So maybe just an additional comment. I'll share this link in the chat box. So there was this study that was recently published in the CKJ. It's a very small study that showed benefit effects of additive of finerenone to SGLT2 in terms of GFR decline and proteinuria. It was a study that was done by Moro, and it had only had about 20 patients, but it's something that perhaps is going to take speed now, as you suggested. And it was just the patients only followed up for about, I think, 8 weeks or so, and there was quite a significant decline in their GFR progression and
Yeah, you know, if you look at studies of SGLT2 and MRA, it has been that the patients who actually have that initial drop in the long run had less cardiovascular and renal outcomes, because it seems to suggest that these patients may actually benefit more from SGLT2s and MRAs. The patients who did not have that initial drop in the long run somehow tended to have worse outcomes. I didn't show that trial per se. When you use either SGLT2 inhibitors or MRAs, you will see a drop in your GFR, and you need to make your patients aware. But subsequent to that, either your GFR will remain stable, or what we are seeing with finerenone and SGLT2, after the initial drop, there is an improvement in your GFR over the next few months, okay? But regardless, even if your eGFR drops, the guidelines and the recommendations are to stick with the drugs, because the benefits tend to outweigh whatever the risks of the small decline in the GFR. In the long run, SGLT2s are known to have cardiovascular benefits, renal benefits, and controlling your sugars. Finerenone is known to have cardiac and renal benefits, irrespective of this short-term decline or a slight decline in your GFR. I would not focus on the decline in eGFR, because that is what is expected with these drugs. Just like ACE inhibitors, when you have a drop in ACE inhibitors, you don't go and stop the drug, right? You still continue. So the same is true for SGLT2s and MRAs, you know. You follow the same principle with these group of drugs.
Right. Thank you, Dr. Dastoor. So maybe a few questions from our participants. Dr. Azel is asking, he wanted to know where, if there's any independent factors, such as race, that is associated with good or poor outcome with the use of finerenone.
I couldn't tell you exactly, but in the trial, obviously, the worst outcomes were not associated with race. They did not compare outcomes in races, or the worst outcomes were patients. What they looked at was proteinuria per se, you know. So they looked at proteinuria as a marker of worsening outcomes. And the patients who had significantly more proteinuria obviously had worse outcomes, right? So they did not look at race, which I think maybe there may be some more data but it's not something like CellCept or something, where we know that CellCept has a better outcomes maybe in dark-skinned patients compared to white patients, or cyclophosphamide is better in European subgroup of patients. So finerenone, at least from what I saw from the studies, there was no comparison between the races, because I don't think they expected any differences between the races. But I will try and have a look, because the study was a multi-centered study. It was in Asia and Africa and in the Middle East. So I can go into the subgroup of this, but I can tell you, at least in the primary study, which was done in New England Journal, they did not look into the race-based outcomes. At least that was not published in the New England Journal when the study was published. Yeah.
Right. Thank you, Dr. Dastoor. Another participant is asking the impact of eGFR reduction with the initiation of finerenone SGLT2. Is this the reason for the reduction in proteinuria?
Obviously,
the drop
right?
in GFR, yeah.
Yeah, same as within ACE inhibitors, right? So when you start ACE inhibitors, the decline, or even when you use CNIs, right, like tacrolimus, cyclosporin, you'll have an immediate drop in your GFR and a GFR-based drop in your proteinuria. But over time, what is the reason for the drop in proteinuria, right? So it is not related to GFR. And as I told you, subsequent to the initial drop, the GFR goes up. But when you look at the proteinuria, it persists and keeps on going down. And that may be to the intrinsic property of these MRAs, right? They are reducing inflammation and fibrosis. And as a result of that, there is less severe proteinuria progressively. And I think that's the reason for this. But yes, the question is right. The initial drop in eGFR is responsible for a certain extent to the drop in proteinuria.
Right. Okay. Thank you so much, Dr. Dastoor. Another question from Kodir. He's saying, briefly explain the mode of action of finerenone in relation to CKD.
Yes, I told you. So at least in diabetic CKD, inflammation, we know the pathology of the disease, right? Hyperproliferation, increase in fibrosis, mesangial expansion. So that is basically inflammation and fibrosis, which is driving diabetic CKD. And mineralocorticoid receptor activation is thought to be one of these pathways. So in the preclinical trials, they looked at the biopsies of rats in which the drug was studied, because it's difficult to do biopsies in humans, right, to show reduced inflammation and fibrosis. But in animal studies, when they used finerenone, and I think I showed you the other trial as well, the LNAME rats, where again they looked at inflammation and fibrosis. So when you gave this drug, there was reduced inflammation and fibrosis. Some of it was obviously stimulated by MR receptor activation, and the use of MR receptor inhibitors such as finerenone reduced that inflammation and fibrosis, and that produced the clinical benefit. I think you would probably see the same benefits maybe if you use spironolactone, but I don't think the study will be done, because if spironolactone in CKD 4 and 3 in this huge population, you'll be chasing hyperkalemia in all these participants, and many patients will drop out of the study. So I don't think you potentially see any spironolactone-based study, at least in CKD patients, But finerenone, because of its less effects on hyperkalemia, we have been able to see do a study and see the benefits. So but I cannot tell you if spironolactone has benefits because there's no study being done. But if you use logic, probably there would be a benefit even from spironolactone.
Another question we have is, can we use finerenone in kidney transplant patients with diabetic kidney disease?
I don't see any reason why not. Just like SGLT2s, they have not been studied in diabetic in transplant patients, but we are using it for control of the blood sugars, and there have been no untoward effects from SGLT2 inhibitors. Obviously, when you're combining finerenone with a CNI, perhaps your risk of hyperkalemia may be higher. So I think you may have to pay attention to that. But basically, there is no interaction between finerenone or CNIs or other drugs. So if you have recurrence of diabetic CKD in your transplant patients, yes, you could possibly use finerenone. Is there any clinical evidence? No, there isn't. If you were to use it, I would be careful about monitoring the potassium levels.
Because they usually also use CNIs together, and both of them can actually cause a negative effect on the potassium. Yes, yeah. No, that's fine. Thank you, Dr. Dastoor. We have a question from Dr. Krabi, and she asks, if she understands correctly, finerenone is mainly indicated in CKD 3 or 4, based on the studies that you presented. So in CKD 5 and ESRD, have we already missed the boat? And do we discontinue if the finerenone was started earlier, if the patient has now progressed to CKD 5 ESRD?
Correct. Yes, Dr. Al-Krabi, you are right. The studies did show that primarily the Fidelio and Figaro studies looked at CKD 3 and 4 for the renal outcomes. For the cardiac outcomes, it was CKD 1 and 2. But that does not mean that you cannot use it. We use it in all CKD. The drug has been approved for CKD 1 up till CKD 4 with an eGFR of less than 25 ml per minute. I also use it in CKD 5 if the patient is not at risk of hyperkalemia, okay? Because the benefits are not only for renal benefits, but also for cardiovascular benefits, right? So just like you would continue using SGLT2 inhibitors now, when patients have a GFR less than 20, we now use SGLT2 even when they go on dialysis. So for SGLT2, we now have data on dapagliflozin to be used for cardiovascular benefits, even in dialysis patients, and we are using that now. So if patients have cardiac events, or to high-risk patients, ESRD patients, we are using DAPA. And I think for finerenone, there is no data on ESRD patients or stage 5, but there are trials which are coming out for, and once these trials come out, then I can definitely say that you could possibly use them for cardiac protection. For renal protection, yes, you may have kind of missed the boat in the sense that once you progress to CKD5, the risk of hyperkalemia will be very high. So that's why that would be the main reason to stop it. And I don't think you would see a lot of benefit in terms of progression of CKD, but you may still get cardiac benefits. So theoretically, you should use it, but at the same time, I would be very, very cautious because if somebody were to have a hyperkalemic event leading to mortality, I think legally you may get into a lot of trouble per se. Yeah. So academically, I would consider it, but legally there may be issues with use of this drug. Yeah.
And any drug interactions between finerenone and other antidiabetics that one would be concerned about?
I am not aware of as such. I think, as I said, our main concern is mostly hyperkalemia as such, and patients who are having a potassium more than 5, we try and bring their potassium down lower to less than 5 first. If their potassium is less than 5, but if they have had a hyperkalemic event in the last 12 months, I would start them on finerenone with a potassium lowering agent. Yes. Not aware of any other significant interaction with any other drugs. If there are any interactions, it may be mainly related to the hyperkalemia related side effects of the drugs. Yeah.
Okay, Dr. Dastoor, if you don't mind, we have about another 2 or 3 questions, if I can just complete this.
Yeah, sure.
So there's a question said, should we consider this drug, that is finerenone, in nephrotic syndrome patients with nephrotic range proteinuria?
I would say no and yes. No, because there is no, if you are being scientific, there is no evidence-based trial. I would say yes, because I am using it. Yes, because
Right.
I know patients with FSGS and membranous, they do have inflammation and fibrosis. And if you believe this theory of the drug reducing inflammation and fibrosis, and the evidence which it has been shown in animal models to reduce inflammation and fibrosis, then yes, I would recommend using the drug. And I can tell you, I am using the drug in patients who have nephrotic syndrome and in patients who have recovered from nephrotic syndrome who are not on active CNIs or mycophenolate but are on ARBs, SGLT2. I do add MRA because I don't have evidence of ACE ARBs and SGLT2s, but we use it. And for that same reason, I'm also using MRAs.
Right. Okay. Thank you, Dr. Dastoor. So there are a couple of questions with regards to heart failure. I don't know if this is the correct forum, but if you don't mind taking a hit at it.
Sure.
So one question is that the neprilysin inhibitors, the ARNIs, along with finerenone, have more favorable effect. And then the second question,
yes, I would
along
think.
the same line, would be, can we use finerenone in heart failure with preserved ejection fraction?
Yes, as I told you, I do not have the data. These are the two trials that are going on. I have spoken to the representatives from Bayer to give me any data they have, but they refuse to release the data. They have studies ongoing in both heart failure with reduced and in heart failure with preserved ejection fraction. They could just give me an outline of the studies. That's why I didn't want to present it. I really wanted some preliminary data, but they refused to release it. So that's why I cannot comment, because I do not have that information. Yeah.
Right. Yeah. But I mean, another MRA, eprenenone, has been shown to be beneficial in these situations. So I would assume that
Yes.
the effect it's a class effect, perhaps.
Correct. Yeah. And my presumption is the studies should be positive. Yeah.
Yes.
I cannot answer this question because there's still no data, so why give a false answer? Yeah.
Right. Okay. And one final question before I hand over to Dr. Lloyd for the closing remarks. Is finerenone beneficial in patients with CKD secondary to hypertension?
I would say it's beneficial in all CKD, but again, there is no data. I would think it would be beneficial because, the end result is always inflammation and fibrosis. And that is the mechanism by which this drug is acting. So theoretically, you may not see an initial benefit, but perhaps if you tended to use the drugs over a longer period of time, you could possibly see some benefits from using this drug. But again, as I said, it is a new drug, and like new drugs, but the company Bayer has chosen to do trials basically on diabetic patients because possibly that's where they thought they would get the highest profit from using this drug, because CKD are diabetic patients, right? So if I was the finance guy at Bayer, I would say, why are you doing trials on hypertensive patients,
Correct.
hypertensive patients? Our benefit would be in doing it in diabetic patients because that's the #1 cause of CKD.
Yeah.
So as time progresses, I think you will see trials in hypertensive, heart failure, etc. And then I could give you more data, right?
Right.
Right now, it's a new drug and there is not much information as such.
Mm.
Yeah.
All right. Thank you so much, Dr. Dastoor. Thank you very much for your time and going over time actually to
Sure.
assist us in answering all these questions. I now hand it over to Dr. Lloyd for closing remarks. Thank you.
Thank you, Dr. Dastoor. I mean, this is a wonderful session. Expertise, clarity, such a complex, subject, and the mechanism of action, the differentiation between SGLT2, and the benefits, and of course bringing in now the confidence trial, and the benefits there with both together, and all the questions. Extremely grateful, and I think your hypokalemia talks now are right on the top. It's so sought after now, I see. And I think this is another talk that's certainly going to be very sought after. It's a wonderful session. Thank you for the time. And, I did make some mistakes on the time. Extremely grateful for, again, agreeing to come on board and, give us this wonderful session.
Thank you.
No words to say thank you. Wonderful it was.
Anytime.
Grateful.
I'll try and do some lectures in the future.
Yeah.
We have been using some new drugs in lupus as well, and maybe after a few months, I could possibly put on that as well. Yeah.
Wonderfully. Thank you so much. I mean, it's so clear, so lucid, and you spend so much time. The beautiful slides, and a big audience today as well. I mean, and they stayed till the end. It's because the sessions are so interesting and it's nice, clear, crisp, and precise. So extremely grateful, Dr. Dastoor. Thank you so much for this wonderful session.
Thank you. Thank you a lot.
Thank you.